Good morning to all of you.
Good morning.
So we would like to welcome Dr. Leonard Ranasinghe from USA. So he is here to do a session on interpretation of ECGs in the clinical setting. So from 9 to 10:45 he will be doing the session 1. So let me just give a very brief profile about him. Dr. Leonard Ranasinghe is a retired associate clinical professor at Kaiser Sacramento Faculty for University of California at Davis School of Medicine, and currently a clinical professor at California Northstate University College of Medicine and a principal investigator of Northern California Research Center, Sacramento. Dr. Leonard Ranasinghe graduated from University of Ceylon in 1969 and came to the United States in 1971 and completed his master's and Ph.D. degrees at the University of California at Riverside. He briefly taught biology, physiology and biostatistics at a university in Alabama before he attended medical school at Loma Linda University School of Medicine in California. He had his postgraduate medical education at the Kettering Medical Center Wright State University program at Ohio and started his emergency medicine practice in Ohio. He has practiced emergency medicine in Ohio, Maryland, Virginia and Washington DC before returning to California in 1988. Since 1988, he worked as a senior physician at the Kaiser hospitals in Sacramento area, and he also was appointed as an assistant clinical professor of emergency medicine at the University of California School of Medicine. He was later promoted to associate clinical professor of emergency medicine. He retired from Kaiser in November 2010. During his years at Kaiser, he took time off and worked as a consultant emergency physician at the King Faisal Hospital and Research Center in Riyadh, Saudi Arabia for 1 year, and as an emergency specialist at the Aramco Hospital in Saudi Arabia, where he became the head of the department for 3 years prior to his return to Sacramento, California. He also worked as a consultant emergency physician at the Palmerston North Hospital in New Zealand for a little over a year in 2011 and 2012. Dr. Ranasinghe now works part-time traveling to different places. He is an instructor for advanced trauma life support, advanced cardiac life support and pediatric advanced life support. And he is a founder member along with Dr. Nihal De Silva of the original college ACHS that later developed into IIHS. Over to you, sir.
Good morning, everybody. I think all of you know who Dr. Leonard Ranasinghe is. There's a picture of him on the wall when he was very much younger. And you can notice that he's wearing a tie there, but he's not wearing a tie today. So because of that, I'm also not wearing my tie. I have it in my pocket. I don't want to look more handsome than he does. He is under, what shall I say? I don't want to say stress. He's very busy in Sri Lanka. Almost everybody in Jahala is his cousin. And they all want him to visit them. And he can't do it because, it leads to family trouble, huh? You came to my place, you didn't come to your place. And he has just come back from Jaffna at midnight yesterday. And I had to wake him up at 5 o'clock in the morning to bring him here to talk to you. Okay, so he may be a little bit sleepy along the way. Just bear with it, okay? And he has been my good friend for the last 20 or 25 years. We have worked together in the United States, in Saudi Arabia, and we, in a way, founded the school together. So I present Dr. Leonard to you.
Thank you, for the introduction. And yes, Dr. Mihal Silva and I have worked together in California in the same hospital system, Kaiser hospital system, and also later on he went to Saudi Arabia in time of my Kaiser hospital, and went to Saudi Arabia myself and worked there for 7 years. You have to forgive me today. I'm not wearing a tie and I'm not wearing shoes. I'm wearing sandals. I injured my hip about a month back, and in fact I was in a lot of difficulty and then it got better, but yesterday getting off the train I injured it again. So I'm limping. And I also have some pain, and I'm taking a pain medication. Can you hear me at the back over there? Okay. Taking pain medication as well, and my feet are swollen, so I cannot put my shoes on. Just my feet won't go in because they're swollen. So my advice to all of you is that don't get old, okay? Stay young. But unfortunately, we can't help it. So anyway, that's the reason. But this is more comfortable the way I am dressed now, and my feet like this without shoes. So I want to talk about ECGs today. Now, what I want to get an idea is how many of you are nursing students? Okay. And are there any other medical fields? What do you study? Okay. Physiotherapy, okay. Are there any government nurses here today? And you already finished and working, or you're still nurses? Okay. Now for physiotherapy students, ECGs are not directly relevant, but it's good to know. But for nursing students, I think it's important that we learn how to look at an ECG. I don't know, as government nurses, do they let you look at an ECG? They're not allowed to. Now in the US, nurses are, as you know, very well trained. The nurses I work with, they'll come and tell me, Dr. Ranasinghe, something's not right with ECG. They are trained there to recognize, because when we are busy, we rely a lot on the nurses. So we respect our nurses as a team member. We don't treat them like somebody lower. You see, it's team member means we are equal. I'm a doctor, but I'm not God. A nurse is also professional. Physiotherapist, we work as a team, respecting each other. So my advice is this year, learn as much as you can to be comfortable. And some of you, maybe most of you, one day would prefer to go to the US or Australia or England, and when you go there, you'll find that it's a different way of practicing your medical profession in those countries, because like I said, you are respected. And unfortunately, I know that sometimes you don't get that respect you deserve here. I'm not going to go into detail that. Now, talking about ECGs, by the way, if you have any questions, raise your hands, okay? And I don't mind, because I want you to understand what I'm trying to say. Secondly, any question, I never consider a question when I teach my other young doctors and medical students. I always say there's no question called a stupid question. The question with you is important. So when you ask a question, I know that is important. Secondly, if you feel a little uncomfortable asking the question in English, ask me in Sinhalese. That's okay. You can ask me in Tamil, but I will not be able to ask that question because I can't understand Tamil, unfortunately. So don't feel bad. We talk, make it a relaxed, discussion, and we'll make it more comfortable for you as much as possible. Now, when you talk about ECGs, when we call EKG, EKG is actually the word here from the first thing from Germany, so they call K or cardiogram in Germany with a K. But ECG is the correct term. In the US, we still use the EKG. So if I say EKG along the way because of my habit, remember, I really mean ECG. Okay, it's the same thing. And sometimes I may have spelled it by as EKG also, because again, doing that. So, so this one is more slide, and the pointer is which one? This right one.
Yeah.
Okay, this is for. Okay. So we're going to have, about 6 different parts in this series, and we'll take time and we'll take breaks, and because this is a course which is usually taught over a period of a month or so, but we are trying to reduce this. And also remember, looking at it, it can become it may look like it's complicated, but I'll make it as simple as possible. Secondly, complicated things are complicated, and we will try to avoid those as much as possible. So the other thing I want to tell you is that you will not be able to remember everything what you hear and see today. But what is important is that you will be exposed to this. So anytime in the future, if I say is the electrical axis of a EKG, ECG, then right now it means, but at least you will be able to go and check, and you will know roughly what it is. You don't have to remember everything we learned today in this particular series. Okay? So now everybody learned in biology what a cell is, right? Now when you take a battery, electrical battery, what do you see on the battery? On top it will say positive, right? And the bottom it says negative. And you have to insert the battery in that certain direction to make the electrical current work, electricity work, for the electricity to flow. So in each cell, you probably learned in biology, there is outside of the cell is positive. Inside the cell is under resting stage, is negative. So how do these cells become positive or negative? There are electrolytes which play a major role, and it's sodium, potassium, calcium, fluoride. Those are the most important ones, but there are other things like magnesium and things like that also can play a role. The cell membrane is a very, very vital part of the cell, the body. The cell membrane is where the electrolytes can go back and forth, and in fact other nucleus can go back and forth. So cell membrane function is very critical. In fact, if the cell membrane gets damaged, the cell loses its function pretty much. Because one thing, it can lose contact, secondly, you cannot have that exchange. So under resting stage, outside is maintained as a positive, inside is maintained as negative. Just like I told about the batteries. Remember, battery, one side is positive, other side is negative. So this is the resting stage. So what happens in the electrical thing? So electrical depolarization of heart cells. Depolarization, I'll explain in a minute what it is the fundamental electrical event of the heart. So depolarization means the cell membrane, remember, outside is what? Positive, inside is negative. Now what is happening is that the positive things go in and negative things go out, making the electrical activity flow from cell to cell, cell to cell. This happens so fast in fractions of a second. So so in cardiac cells, you have in the heart, you've heard of the pacemaker, right? This pacemaker, the primary most important, normal pacemaker is located on the right upper corner of the right atrium, and that's a natural pacemaker. And those cells have the ability to have this depolarization automatically. It's programmed automatically. You don't have to have anything to do that, but other external forces and internal forces can change its behavior. But under normal circumstances, the positive to negative thing can happen automatically or spontaneous, same way. Now, other cells usually require some kind of a stimulation. For example, muscle cells. You see, there has to be a stimulation either by touching or internally, and those things need stimulation. Whereas pacemaker cells don't. So it is propagated from cell to cell across the entire heart. The electricity flows. So from cell to cell to cell to cell. When you think of it, it looks like it's a slow process, but as you know, it happens so fast. Electricity is very fast. By the way, if my accent makes it difficult for you to understand, let me know, because sometimes I pronounce words differently. So at the end of the depolarization, what happens now? All the cells have now, outside have become negative, inside become positive, and once that happens, now the cells have to return to the original state by a process called repolarization. Repolarization can outside positive inside negative So that process is called repolarization. So this is the fundamental process of electrical activity of the heart. All what we are going to learn actually is based on this principle. Okay. So here's the spontaneous depolarization. Now if you look at it, you see that outside would have been, all this would have been positive. Now some of the negative things have come out, few positive things have come inside. Same thing here, okay? And then next one, you can see that the process is now going in both directions gradually, all positive inside. And the repolarization is now start from the opposite end, start from negative there, and gradually these go back to being negative. So this is what happens in the cardiac cells and other cells depending on whether it's pacemaker or not. Okay? Any questions so far? Okay? Right? So, what are the different types of cells in the heart? There are three main types of cells in the heart. First is, like I told you, pacemaker cells. Pacemaker cells is like the battery, the power source that's spontaneously offer the electrical flow to be released from the heart. Once that happens, you see that it spreads across the heart, which I'll show you in a little bit. Secondly, you have the conducting cells. So you have the wiring. So when you turn the switch on, electrical forces, electricity flows through the wires. The same thing in the heart has conduction cells. That's the hard wiring of the heart. So the power starts from the sinus node, pacemaker cells, goes across, then it goes to the conducting cells, and it conducts signal. So, you have a question? No. Then you can scratch your head, that's all right. Myocardial cells, finally. What are myocardial cells? You will probably learn in biology. Is actually the heart muscle. Myocardial means muscle, cardial means heart. So myocardial cells means heart muscle. So finally those heart wiring will take the electricity into the heart muscle, and the heart muscle will now contract. That's how the heart muscle will respond. Okay. So here's a good picture. Oh, let me say something. The lectures are based on this book. And unfortunately, I wish we had time to get this copy, but what I'll do is I will donate this book to the school. Actually, you made a copy, right? Yes. If anybody wants, but I can, leave this book if you don't have enough, but if you want to get copies done, or you can go online and buy a used book. You see, eBay has lots of, old versions. It's very little changes. The heart doesn't change over the years. So more except few things have changed in terms of physiology. That if you buy an old copy, you can buy it in terms of US money for about $5 actually. The actual new book is about $60, the latest version. But I strongly recommend because these pictures are very good in this book. So, like I said, so you have the pacemaker cells. This is the right atrium, this is the left atrium, right ventricle and left ventricle, because we are looking at it. So it's kind of opposite. Our left is actually the right of that one. So pacemaker cells, it originates the electricity, and then that spreads all across. And here's the hard wiring I told you, conducting cell. And this is called the AV node. We'll talk about it more. So sinus node, or it's called sinoatrial node, SA node, they're all the same thing. And this is called the AV because it's an atrioventricular node. That's right at pretty much between the atria and the ventricle. And then you have the bundle of His. This is called the His bundle. Some people call it His bundle. And His was actually a name. So he is the one who discovered, or she discovered it. And that's a very, very microscopically short one. And then it branches into two major ones. So one is called the right bundle and another one is called the left bundle. Then they break into minor small nerves called Purkinje fibers. And Purkinje fibers are the ones that go innervate, meaning penetrate the heart muscle, giving that final stimulus to the heart muscle to contract. Okay? So, pacemakers, what are the three main cells in the heart? Pacemaker cells, action cells, myocardial cells. You pass the test. So we talk about the sinus node now. Like I said, it will, fire automatically. If that doesn't fire automatically, you're dead. But not necessary. We'll talk about that a little bit later. So what happens is the sinus node. This is a very important node. Sinus node usually has these electrical pulsations about 60 per minute, maximum of 100 per minute. So that's the normal average range between 60 and 100. So we call the normal sinus rate. And that rate, if it is below 60, we call it what? Everybody know? Sinus bradycardia, if it is coming from sinus node. If it is more than 100, bradycardia. So that's what we see and so on. But essentially normal rate is 60 to 100. So then you can see how the electrical forces go spread across the two atria, and then now it comes to the AV node. Once it comes to the AV node, actually, then this is the value we talk about a little bit, and it goes to the bundle his, and then it goes to the left and the right. Later on, you learn that left again splits into three different branches. So we talk about it a little later. So when you talk about waves in the heart, the ECG waves, what you see on the ECG paper, the things you have to remember that these are important things to remember. Duration, how long does each event last? Duration is that. Although you can see it in the picture here because it's magnified, is actually a fraction of a second. And then amplitude. Amplitude can be the electrical physics of current, electrical force. That means, so that is depicted, this is the duration in fraction of a second. Amplitude is, you see how strong is the current. That's the amplitude, how strong. If the current is weak, the amplitude is low. Later on we'll see what kind of medical problems cause the amplitude to be weak. And so amplitude depicts the electrical strength. Duration, it says how long. So if the heart is have a problem, it could take a longer time for it, or if there are conduction blocks. Secondly, configuration, the shape of the ECG wave. So we'll talk about that, how different shapes can happen. ECG paper is a standard paper. Each of these small squares, in terms of duration, is 0.4 of a second, 0.4. So 0.4, yes, right here. You see that? Each of those small boxes. So small box is 0.04 second. So if you consider that 0.4 second for each box, if you count a big square, big line, see this big line? How many squares between two big lines? 1, 2, 3, 4, 5. So how many seconds is that for one square? 0.5, 0.4 divided by, multiplied by 5, 0.2. So that's what it is. So that's how we will read ECGs to get an idea. It's better if you memorize this part, because you see this comes all the time. Now, same way, it's 1 millivolt up this way. So between these small squares. Alright, so P wave. So what is a P wave? Anybody? Any guesses? It's okay if you make a mistake. What does the P wave indicate? So So we are talking about the P wave.
Want to go to the bathroom?
That's one way. See, P in US means you're going to the toilet. So, and any guesses? Dr. Silva's answer doesn't count because she knows this stuff. The P wave, remember, P wave means the contraction of the atria, the right and the left together is called P wave. Because atria is smaller than the ventricles, the P wave is smaller than the ventricular contraction. So we'll come to that in a little bit. But if you look at it, which one contracts the first? Where is the sinoatrial node, SA node? In the right atrium in the top corner. So which one contracts first? Right atrium. Right atrium. So first part of the P wave, then it's always the right atrium. Remember that, because this becomes important later in certain diseases like COPD or COPDs, chronic obstructive pulmonary disease, pulmonary hypertension, pulmonary stenosis. So these things become important. You can look at an ECG and doctor, I think this patient has pulmonary hypertension. They'll be impressed if you just tell them that, looking at the ECG. So you're talking about, you see, first part of the P wave is right atrium. So by the time it comes to the left atrium, it's this part. So we have put it as exactly half, but not necessarily always. But first part of the P wave, remember, is the right atrial contraction. Second part of the atrial P wave is the left atrial contraction. So it both have to contract. The electricity force has to go from here to there, and both have to contract before it goes down. Because you see, in the heart, if these are not properly coordinated, what will happen if both this and this try to contract same time? Because the atria and the ventricles try to contract same time, which happens in certain bad diseases, then the blood cannot go in, because you see, both are trying to push the blood. You see, so it has to be coordinated in such a way that when these are contracting, this part has to be empty, so it can receive the blood from the atria. Okay? Am I going too fast? Then we want to slow down. Okay? Alright. So now what happens now? The atria have finished contracted, and the AV node is now receiving. So to review, we have the pacemaker cells, bundle of his, right bundle branch, left bundle branch, and now I want to show you this part. No, before I get there. So what's this again? P wave. First part of the P wave is what? Right atrium. Second part of the P wave is what? Left atrial contraction. Why is this line flat then? You. I can't hear. No? Exactly. You see, the idea is to put there some electrical pause there. Electrical pause meaning the electrical activity is kind of stopped for a minute. The reason is because the heart is designed, like I said, to finish contraction and for the time for the contraction to complete. So if it goes immediately, then the ventricles will try to contract, then it becomes less. So there's a very short pause. You see, in fact, we'll talk about the lines later, and that's at the AV node before the electricity goes down the bundle of this and the Purkinje fibers. So that electrical pause becomes very, very important. In fact, in certain diseases, later on we'll talk about that, and what happens goes that electrical pause. So it has now, after that pause, then it will go down to the AV node. So AV node is like a gate. You see, AV node is like a gate. So when the contraction comes from the electrical contraction comes from the atria, the gate is closed for that brief period of time. The gate to pause gate. So once that goes down the gate, then it goes down the bundle of his into the right and left. So here's the AV node, here's the bundle of his, and I told you divides into two major ones. Right bundle branch and the left bundle branch. Right bundle branch goes where? To the right ventricle. Right bundle branch goes to the right ventricle. Remember that, because later on when we talk about bundle branches, it becomes important. So just think of this picture. This is one of those things you should remember. With this picture, how the bundle of is splits in the right bundle branch. Left bundle branch is very important, more important than right. Of course, both are important, but left is more important because which does most of the work for the heart? It's the left ventricle. So left ventricle is actually becomes stronger usually. And if left ventricle fails, that's how people get primary heart failure, in fact. So left ventricle, has three bundle branches. So the main left bundle splits into anterior, fascicle. It's called fascicle, meaning like a little branch. Okay, and then it has the septal branch, which is very small, and then the posterior fascicle. So the heart ventricles have in the middle, what is it called? Interventricular septum, which divides the left and the right ventricle. That septum also needs electrical current. So that's why this particular branch provides a smaller one called the septal fascicle. And then the anterior branch, anterior fascicle, goes right in the front, from the front of the heart along the left side. That is a very, very important branch, you see, because it applies the major AC areas. And then you have the back of the heart, which is posterior posterior fascicle, and then they all split into Purkinje fibers, and they're kind of interconnected. Any questions so far? So this is still, we're talking about the anatomy. So we now want to talk how the ECG waves happen. On the SA node, electricity goes to the right and the left atrium, making the P wave. And then the AV node has that little gate which causes the electrical pulse. And then from there it goes down the right bundle of his to the right bundle branch and the left bundle branch, making the ventricles contract, creating the, what we call what wave? QRS wave. Why is the QRS wave is much bigger than the P wave? Yeah, but why is it bigger? Ventricle is much thicker and bigger. You see, ventricle is bigger. Yeah. So that's fine. So first wave, downward wave. Now we have done the P wave. We have done the little pause, which is called the PR segment. We'll talk about it in a little bit. And so we are talking about Qrs complex. QRS does not mean there's always QRS, you see, but you have to remember this part. So memorize this part one later on if you can do it right now, because this is how you recognize which is in the Qrs complex this patient has, this particular lead has. So the very first wave which goes down after the PR segment, the pause, the very second, if you see a wave going downwards, downward waves meaning is negative, by the way. Going up means positive. We'll see that all in a little bit. So first downward wave is always called Q wave. Now Q wave is a very, very important wave. There are Q waves which are normal in certain situations, but there are, if you see a bigger Q wave, that is abnormal. So we're going to come to that as we go along. So that's why that Q wave is a very important wave to remember. Any first wave going up, whether it's the very first one or after the Q wave, any wave which is going up, first one is called R wave. That's the R. If you see a second R wave going up afterwards, we call it R prime, meaning R with a positive. And then any Q wave, any wave going down after any R wave is an S wave. So these things, you'll see some pictures and I will explain, but I think this evening, memorize. Not this evening during a break, lunch break. I want you to memorize because this is something we will ask later on. So it's a little confusing, but remember the very first one going down is Q. Very first one going up is R, regardless of it. So you see some pictures. So here's a normal Qrs complex. What's this? What's this? It's a pause, which is called the PR segment. Okay, PR segment is that. Now, what is this? Because it's the first one going down. So that's the Q wave. And what's this? R wave, because it's the first one going up. So this is although it's called Qrs complex, but there's no S wave there. So there's no second wave going down. So let's talk about this one. So what do we have here? Q, R, and now there's a second wave going down. That's a S. So QRS. That's a complete QRS. So do you see a Q here? No. What's this one? First one? R. But then this wave is coming down, so it becomes S. And this one R prime because it's second R. So this is a RSR. Now this one is what? R. This wave going down is after the R. It's not the very first wave going down. If it is very first wave is a Q. So first wave going up is R. Any wave going down after that is an S. And this one is, the first one is what? Q, R. So this has only QR. So this kind of combinations you find in ECG. So when you see an ECG and you can look at, oh doctor, this patient has a Q wave on this one, and this Q wave is there, but it's not important. Like you can, we'll talk about which Q waves become important, which we know which are not. And this one is only one wave going down is called Qs. It's actually a Q wave, but it's called Qs. And this has only one going up is R. So depolarization of the septum. Now I told you some Q waves are not normal, not significant. So this Q wave is small, and the reason because this Q wave is where the septum is electrical conduction in the septum, going to the septum. Why is it going, Q wave? Q wave is what I said, going negative, right? So here's the septum, right? The electrical forces are coming from, in this way. So anytime electrical force goes against or opposite, it's a Q wave. So you don't need to remember, it's only complicated. But anyway, remember the idea is you see that Q wave, small Q waves in these situations are normal. And abnormal Q waves are much bigger than that. So we'll come to that later. A small Q wave, if you see, it's not significant, it's not very important. So, what happened in the ventricular repolarization? Now, remember, depolarization is when negative goes outside and positive comes inside. And once the whole thing has completed going through the atria, through the ventricles, and once the ventricles finish contracting, they have to go back to the inside being negative, outside being positive. That's called repolarization. Depolarization is when positive minus goes inside, positive goes inside, negative goes outside. Repolarization means now it's restoring the original state of inside negative, outside positive. So when that happens, you find, you see this part and the T wave. T wave is the repolarization. This is extremely important. Trust me. It can be life-threatening situations can happen. So learn to recognize the T waves because it can be important. Now we'll talk about that later, what happens in certain situations. So, this is all the depolarization part, and from here it becomes repolarization where heart returns to baseline. So this happens, as you know, so fast. Okay? So T wave is, but also you can see that the T wave is usually duration. See the duration meaning this way is longer than this, right? So that duration is because depolarization is a little bit slower process. It takes a lot more energy for the cells to return to normal state. So it has to work a little bit harder. So because of that you find period is longer. So now we want over the lines. These lines are important because that's how you sometimes recognize a heart attack. So let's talk about the lines. Beginning of the P wave right here. Huh? And this is the beginning of the QRS wave right here. Beginning of the P wave to the beginning of the QRS complex. This is the beginning of the P wave means beginning of the atrial contraction. Beginning of the QRS complex means beginning of the ventricular contraction. So beginning of P wave to beginning of QRS complex called PR interval. PR interval. This is important to know. Okay, and I am not going to place a lot of emphasis on this, but this is what we talked about, the electrical pulse. Remember, after the P wave, we give a little time for the AV node to give time for the gate to open, and the gate is kept closed until this is all completed, and then you got it. So PR interval is important, and then you have we see the other interval we talk about in the next one. Should be here. So the next one is the QT interval, which is beginning of the QRS complex to the end of the P wave. That's called QT interval. That is also important, very important. So PR interval, QRS complexity, the width, and the QT interval becomes important. So we have the PR interval right here, which is from the beginning of the P wave to the beginning of QRS. PR segment is the pause, and then you have the QRS complex. That is the beginning of the QRS complex to the end of the QRS complex. Is called the QRS interval, or how wide the QRS is. And normally it should be 0.1. So remember that 0.1 should be the limit. If it goes beyond that, there's a problem. So we'll talk about that. So, and then we have the ST segment, beginning end of the QRS complex to the beginning of the T wave, called ST segment. Why is ST segment important? Anybody? That's how you diagnose heart attacks most of the time. So ST segment is very critical, which is the beginning, end of the QRS complex to the beginning of the T wave. And then you have the QT interval, which includes all that. So these later on you can memorize, because these are important things. And then you will not never forget that once you get a good feel of it. Right, this is another summary of it. And we don't need all that. Most important ones are the PR interval, QRS interval, ST segment, and the QT interval. Those four. And then of course you know the T wave is, that's the T wave which comes after. So any questions so far? No? Okay. If you have any questions, we'll cross with you. So, here's a wave of depolarization moving through the heart. Here is the young lady here, and electrical force officer is now moving towards her. See if it is here. What happens now to the electrical activity? I am going towards her. Electrical activity goes positive. Meaning, I like her, she's a very good student, therefore I respect her. For some reason, she doesn't like me as a professor, so I move away. Now what happens to the wave? That's why you get it. Some ECG leads, when you look at an ECG, some are going up, some are going down. The reason is that electrical force is moving towards that electrode. So you have electrodes here, with a here place or so if the electrical force is going towards that lead, it's positive, going up. If the electrical force is moving away, that registers negative. So that's easy to remember, right? Now you know that. So in this case, if you look, here's the normal electrical force goes from right to left because left ventricle is the strongest one. So if you place a lead here, which is the, we'll talk about different leads later, lateral meaning sympathetic, lateral meaning one that particular samani we talk about the lateral to the left side of the heart, then that makes it a positive one. Make a way negative because it is going away from it. So anything which goes towards positive, anything which goes away negative. But if it is right in the middle, initially it is coming towards this lead, right? Initially it is coming towards it because it's here, so it's coming towards it, then it goes a positive one. But after it passes it, it's going away from it, so other part is negative. So it has both positive and negative because it is in the middle. So initially it's coming like that towards it, so it's positive, then it goes away from it, then it generates some negative one. So when you look at an ECG, when you see positive line, then immediately now you know that electrical force is coming towards it, and in other cases electrical force is negative, it is going away. So when we talk about ECG, so three people are looking at the elephant. This lady is looking at saying, my goodness, I can only see the butt of the elephant. This elephant only has a butt and a tail. That's all this animal is about. And this person has the elephant covered on both front and end. Then, oh, that's a big belly, like Dr. Ranasinghe, and legs only. And he's saying in the front, and he's saying, this animal only has a trunk and some tusks, because he cannot see the back or the legs. So, ECGs are like that. ECG is where are you looking at from? If you're looking at from one side, that ECG will show that part of the heart. If it is has a lead on another side, it will show that part. This is why we do 12 lead EKGs. So we can look at 12 different angles, which gives a better picture. In fact, there are many times when I have an ECG, sometimes I tell the ECG technician, you see, I want 2 additional leads played, 3 additional, sometimes extra one on the right, and put 2 in the back. And that, so you can have more leads. More leads you put the better, but the standard for ECG is 12 leads. So 12 lead will give you pretty good idea about looking at the heart in different angles. So when you say 12 lead, that means you see all these things looking at together, then you see they get together and say, oh yeah, they even had a pretty bit faster, valigi, and you say, oh yeah, this animal has all these parts together. So remember, it's a 3-dimensional structure. Heart is a 3-dimensional structure. So it's better to look at it from different angles. So that's why we place ECGs in a different way on the human body. And how many of you, do they learn how to do ECGs here? In the class? Huh?
Very good.
Huh? They do? Basic, yeah. But I mean, do they learn how to place leads and things like that? Yeah, 12 leads, yeah. Well, not the monitoring leads. I'm talking about 12 lead ECG, yeah. Okay, it's something maybe they need to learn because it's a good idea. So,
They don't have it in the syllabus.
Yeah. Machine, I see, okay. Yeah, just to, even if you, without the machine, if they learn to place leads, it's not a bad idea. So something maybe you can do. It takes only about half an hour to do that part. So, vector. Now, this is very complicated. Okay, remember I told at the beginning, if it is complicated, I'll tell you, because complicated things can be complicated, although if I have another hour, I can explain this very in a simple way, but we don't have time to do that. But remember vector. In a very simple way, I'll explain what a vector is. Here's the Sri Lankan football team we call soccer. On this side, here's the Indian soccer team, football team on this side, playing soccer. So Sri Lankan team is playing the ball which way? Yeah, again, our goal is this side, and Indian goal is this side. So where do our team try to score? This side. So where is the ball they try to kick? They want to kick towards this goal, right? But during that time, sometimes they kick the ball to the side, right? Sometimes they to this side, and sometimes here, sometimes here, sometimes here. So all the ball can be kicked in different ways. Rarely they'll kick backwards if they need to help, but most of the time ball is kicked forward, but could be different angles. But ultimately, the main idea is what? To the ball to go towards the goal, opposite goal. That's the vector. So summary of all those electrical forces going in different directions, the summary of all the electrical forces is going in one direction. So in the normal part, that is called the vector. So that's essentially is what the vector means. So in this case, here's the vector going in that direction in a normal heart. So we'll touch on it, but I don't want to explain how to find the axis and things like that. I'm not going to go into it, but that I teach young doctors and medical students because they have to learn, because axis is important. Later on, maybe I'll tell you a simple way to get an idea. How do we place leads? So there are what we call the limb leads. Limb leads essentially is in the what we call frontal plane, going in this direction, vertically and up and down and downwards. It's not going this way. So 1, 2, 3 and AVL, AVR, AVF all in the frontal plane. So how do we make the lead 1? Lead 1 is left arm is made positive. The machine can do that. So that's why you attach leads sometimes in the wrist or sometimes here. Anyway, it's in the left arm. The other one is you put in the right arm. Then you put leads in the legs, both legs. So left arm is made positive and the right arm is made negative. So left arm, that is given, these are things which you give in the standardizing, we give 0 degrees because it is positive. So if the electrical force is going in this direction, where would the EKG go? Up, because it's a positive one is left arm. Second one is both legs are made positive and the right arm is made negative. So if electrical forces go down, and that lead will show a positive up one again. Remember, anything which goes towards the lead is a positive picture. Then lead 3, both legs positive and left arm negative. But you don't have to memorize this, because you see, only you need to learn how to place the leads. That's why I think maybe in your lab, physiology lab or something, they should include that as a one session. And because the machine will automatically do this one once you place the leads. Then we have all 3 augmented leads called A. So that's why you have an A in front. And they make one lead positive and all the other leads together are made negative. Whereas here, either the right arm is negative or like that. But here one's positive, everything else made negative. Same thing for the AVR, right arm, for R, left L, left arm, and then F is for down below, which is legs positive. So these 6 are called the limb leads. And those limb leads go which direction? Only up and down and sideways. It's in a frontal plane. It doesn't go this way. It only goes up and down or sideways. So here's one. Okay, lead 1. Lead 1, like I said, left arm is made positive and right arm is made negative. Therefore, if the electricity force goes this way, this is given 0 in the circle. So 0, then this is 90, this is 180, like that. So this is 360, like that. Angles are being negative. These are standards. So you may want to remember this stuff, but remember lead 1 is positive. Lead 2 is going in this direction 60 degrees, lead 3 is 120. You don't have to memorize this part, but if you know where to place the leads, this is automatically calculated. But I want.
Do we have to place the lead at the end of the arm,
No.
middle of the arm, up here?
Not necessary. Not necessary. As long as you keep it in the somewhere in the arm, it's good enough. Yeah. The tradition has been to put it on the left, but some of our new machines can do it anywhere in the arm. The latest machines are very, very good. And the augmented leads, similar way, one is made positive, all the others are made negative, and the angles are different. So I'm not going to I'll show you in this one now. Here's the frontal plane candidates are up. So you have the lead 1, 0. Lead 2, 60. Lead AVF is plus 90. Lead 3 is plus 120. And because make positive candy plus and angle geometry you make 180. It was a make a minus 90, make a minus 30. Yeah, again, I don't want you to memorize it, but this is a good thing which you can always look up. You can always check and say where the lead 1 is, where the lead 2 is, like that. So, what is important is that where do these leads, the way it is placed, you see which part of the heart does it show. That's important to know. So, lead 2 is 60 degrees, and now if you put that on the heart, see where it goes? It goes pretty much to the bottom of the left ventricle. Lead AVF is directly below the bottom of the heart in a way, and lead 3 is on bottom of the right ventricle. Because yes, right, this is the right ventricle, this is the left ventricle. So these 3 leads essentially is showing the bottom part of the heart. The left bottom, the middle bottom, and the right bottom. And those are called inferior leads. The inferior word again, anytime you look at the body, this up is called superior, anything below is called inferior. In fact, if I say something, even here is inferior to my scalp, because they get at me. Then if I say from my nose to mouth, my mouth is placed inferior to the nose. So anything below is inferior, anything above is superior. So because this is these 3 leads, now you can see it. If you look at that picture here, these 3 leads are at the bottom. Here's on the right, left bottom, right, almost in the bottom. And so 2, 3 AVF. Remember that 2, 3 AVF are inferior leads. Very important. You'll find that when we talk about heart attacks. And where is lead 1? Lead 1 is going to which direction of the heart? What side of the heart? Left ventricle, but left what? What is the side called? Lateral. So you can see it's left lateral, 1, and AVL, the other one. So this is the limb lead, this is the augmented limb lead. The AVL is going to minus 30, that is also going to left lateral. So 1 and AVL is actually showing the left lateral part of the heart. Therefore, bottom. Where does the bottom of the heart? It's on sitting on top of the diaphragm. So anytime you see inferior leads, remember it's the heart which is sitting on top of the diaphragm. Now this I am talking about a normal heart. Now sometimes you see hearts, people are different. So sometimes the heart has rotated. So that's a little different, but we don't need to go into all that. But have you heard the word dextrocardia? That means everything is in the opposite direction. So, but we are only going to talk about the normal hearts today. I mean, normal anatomy, except when it comes to certain diseases. So, these 3 are inferior leads, which show the bottom of the heart. These 2 are lateral leads, showing the lateral side of the left ventricle. And then what else do we have? Then we have right-sided lead. If you put one, then you can see the right side of the heart. That's a special thing. So sometimes I tell the ECG, I want you to do right-sided lead, and I want you to do posterior lead, and I'll tell you why later on, why those things become important. But for now, 2-3 AVF are what? Inferior leads, looking at the bottom of the heart. 1 AVL are what? Lateral leads, looking at the left side, the left lateral of the heart. Because you see, the blood circulation determines, you see, which artery gets blocked, which part of the heart gets blocked. So, now we talk about the other leads. So we have 6 already, right? 1, 2, 3, then AVR, AVL, AVF. 6 leads are done. We have 6 more leads called precordial leads. The limb leads 1, 2, 3 and AVR, AVL, AVF are called on the frontal plane, going up and down and left and right. So it's all in the surface. Whereas precordial leads are also called the chest leads. They go anterior and posterior, or posterior lateral, so goes this way, not up and down. So those leads are placed on the heart here, and they are named V1, V2, V3, V4, V5 and V6 standard. Like I said, sometimes I have an extra lead here, I ask them to do that. Sometimes I ask them to do 2 more leads in the back, because that way you can diagnose the posterior heart attack, and posterior heart attacks can be missed because people don't see the typical ST elevations on those ones. So we'll come to that in a later chapter if I'm still alive by that time. So how do we place these leads now? V1 is good. So what the EKG technicians do is if you see them doing it, they'll start feeling like this, looking for the space between the ribs. Go 1, 2, 3, 4 like that. They'll place V1 to the right of the sternum on the 4th intercostal space. V2 is directly across on the 4th intercostal space on the left side. Okay, see that? V2. Then I'm going to go to V4 next, which is the 5th intercostal space in the mid-clavicular line. So here's the clavicle. You come down directly in the middle of the clavicle to the 5th intercostal space, and you put the 5th one there. Then V3 is placed between V2 and V4 is the V3. So that's easy. After you place the 5th, you just go to the middle of between the 2 at an angle and push down. So V6 then is the mid-axillary line. Axillary and keel, take it down, come to the 6th intercostal space, and 5th intercostal space, and then V5 is between 4 and 6. Very easy. If you remember the 3 leads, you see 3 4th intercostal space, left and right, or right and left.
Place it in the mid-clavicular line.
Dr. De Silva's specialty is at the other end. But he has now specialized in all the areas. But when he was in California, he specialized in a different part of the body, which I cannot name because a lot of ladies are. So, precordial leads are placed like that. V1 will look at this part of the heart. Which part of the heart is that? What is? Right ventricle. And V2 is what? What is the closest structure to the V2? I see the lady in the pink wants to answer. Great. Perfect. It's almost close to the ventricular septum, a little bit to the right ventricle as well, but primarily V2 is a ventricular septum. So, V3 is primarily little bit in the septum, but now it's getting to the left ventricle. 5 and 6 essentially left ventricle. Also, what part of the heart is there? 5 and 6? Huh? Left lateral, right. So, left lateral leads. We talked about left lateral before, right? What are those? And this young lady, you. What was it? Yes. One and AVL. Yeah. Not the one and AVL. Yeah, you just call one. That's simple enough. But you're right. One and AVL. So one and AVL and 5 and 6 are lateral leads. Yeah, these are important because when you tell the doctor, he sees, no, this is what it is. I don't think the doctor will say, I will have it. Yeah, you what with the mic here? Now I learned the band now. So if you want to review the anatomy with the leads, right ventricle is primarily, it is anteriorly Ganisara, medially Ganimada. That is primarily V1. Septum is V1 little bit, V2 little bit. Left ventricle, posterior and laterally is 4 to 6. And the leads on the anatomical are, right ventricle is 1, V1 and AVR because they are right ventricle. So anterior are V2, V3, V4. So if someone comes and you can look at the ECG and say, oh, he's having an anterior myocardial infarction. How do you know? Because V2, V3, V4 is showing something important. So we will talk about those when we look at, we'll come to the lecture on heart attacks. That is, if I'm still alive by that point. But maybe a cup of tea might keep me awake later. So V2, V3, V4 are considered anterior. So when you go home this evening, try to read these things over the next few weeks. Try to memorize these things. These are important to remember, but you don't actually even have to memorize if you know where the leads are and you look at the heart. You put the picture of the heart and say, oh, lead 1 is 3, 5 and 4, 6 are here, like that. It's not difficult to remember if you put with a picture rather than memorizing it. 1, AVL, V5, V6 are left lateral. 2, 3, AVF, inferior, the bar. V7 and V8, like I said, if you do those, that will show the posterior part of the heart. Otherwise, posterior part is normally not done. There is an indirect way to look at the posterior heart in the ECG. We'll talk about that in the so when I see an ECG and when I see not ST elevation, but I see ST depression, then I suspect posterior heart attack, but I'm not going to talk about it now, otherwise you'll be confused. But when we come to that, you'll see it's not very difficult. And I'm trying to make it as simple as possible. So let's pause for a moment and tell me, have any questions? Okay, Dr. Silva, you have the test ready now? Quiz? You're lucky she forgot to do the test. So, normal ECG. Where does the electrical activity start in the heart? They say no. Fixed, permanent. Everything else is not normal. If it doesn't come from the SA node, it is not normal. It is abnormal. It follows the conduction pathway. If the electrical activity starts in the SA node, it will go from the SA node to the right atrium, to the left atrium, and it will come to the AV node, and what happens? Electrical pause, because the AV node acts like a gate to keep the heart ventricles from contracting for briefly, and then it opens, and then from AV node it goes down the bundle of his, and that pathway goes to right left bundle branch. P wave and Qrs complexes are normal in duration and amplitude if it starts from the SA node. So everything which comes from the SA node, consider it will be normal. Intervals and segments will be normal duration. Those lights we talk about, they will be normal. Heart rate, meaning how fast the heart beats, will be normal between 60 to 100 if it is coming from the SA node. Normal. And occasionally SA node can be faster and slower, but we'll talk about that later on in this chapter. So, yes, that's a review of what we did so far. So SA node firing spontaneously, automatically. It has the automatic potential capability. And the electricity will flow to the right atrium and to the left atrium. And then it will come to the node, brief pause right there. And after brief pause, we go to the line of this, and we go to the ventricular signal from the right lung and then right lung will be left lung. You already saw that about 5 times. So the more you know about this, the better. Because this is a very good picture to keep it in your mind how it goes and how the normal, way the heart should act. Now we got a real ECG. So I want a volunteer to come up here and show me the different sections of the ECG, what you know so far. So if you don't volunteer, I'll ask Dr. Silva to select a volunteer.
You take it, choose the prettiest ones first, huh? All right?
Well,
Choose the prettiest one.
yeah.
The prettiest one. See, I pulled you.
Now that's not fair because to me they all are handsome and beautiful. So that's not fair.
I didn't say handsome, I didn't say beautiful, I said pretty.
Now, remember, it's okay if you make mistakes. You learn sometimes by making mistakes, and so absolutely okay. In life, don't feel bad if you make a mistake. In fact, I can't speak how it works here, but in the US or in Australia maybe, but I lived more than half of my life in the US. And in the US, if you make a mistake, you have to admit that. You have to document it in the chart that you made this mistake, and then you have to talk to your supervisor. Because you see, later on, if they find out, not only you can get fired, you can get fined, you can get legal. If you document it and talk to the supervisor, and then they will talk out to the patient, you will be much safer. So making a mistake is huge. Okay? So remember, nobody is perfect. And I've done my medicine practice for 40-some years, but I still, occasionally make a mistake. Interestingly, most of the time who comes and talks to me about it? Nurses. Nurses come and tell me, you see that the lights went off. So, and I tell them, go and get a power, generator. So, what I'm saying is that, that's how we work as a team. And so, and he's lucky, he just escaped it.
He's pretty lucky.
Pretty lucky. So, all right, let's take a 2-3 minute break if you want to stand up while the power line come back because we need the slides. Okay. Anybody wants to get up and stretch your legs and how is it going so far? The speed is okay? I am not going too fast. But this was one of the mistakes sometimes I make is I try to go too fast.
Oh, that's speed level. Speed level.
There is a subspecialty